My name is Steve Boyce. I am a practicing surgeon in private practice, so I'm not an academician, but I do have a lot of experience and the privilege to have taken care of a lot of patients over the years. I do have some disclosures. I am a paid consultant by Ethicon Endosurgery. I basically train other surgeons how to do procedures. And as you heard, I do have an ownership interest in Bariatric supplements. I was asked to talk about the long-term medical concerns of the bariatric patient, and there's so many things that we could talk about. I tried to pick a few, given the time allotted, that I thought might be a little bit misunderstood. And so with that in mind, we'll talk a little bit about skin, the dumping syndrome, kidney stones, nutritional deficiencies, and weight. Skin, you know, my patients are very concerned about excess skin after weight loss. So much so that it is almost universally brought up at the time of our initial consultation. And it is a concern, and there can be medical problems with excess skin in terms of skin irritation and rashes and pain, and it can interfere with our ability to lead an active lifestyle. So along the idea of trying to minimize the excess skin, I think it's important to do the things that are promote good skin health. And so hydration is one. There's a lot of water in the dermis of the skin, which is where the glands are and the blood vessels live. And in order to have good, healthy skin, you need to have good hydration. So I recommend following your medical team's advice on adequacy of fluid intake. Next is smoking. Basically, don't do it, right? Smoking is terrible for the skin. It causes premature aging of the skin and wrinkles. It hurts the skin's elasticity. It causes a severe vasoconstriction, which means the blood vessels get very small and tight. And it limits the delivery of oxygen and nutrition to the skin, which is imperative for good skin health and healing. Now, sun exposure. Excuse me, I'm sorry, I didn't. Here we go. Sun exposure or tanning beds are equally bad. Of course, that is exposure to ultraviolet radiation. Ultraviolet radiation causes what's termed as photoaging to our skin. It does cause premature aging. The radiation produces free radicals in the skin. These are very damaging molecules. They can actually break the DNA molecule inside of a cell. It can lead to precancerous and cancerous skin changes. And so the American Dermatology Societies recommend basically don't go out in the sun. So if you're going to be outside, obviously use appropriate sunblock and stay covered when you can. Next is nutrition. So with respect to free radicals, a good healthy diet with vegetables and fresh fruits provides a healthy dose of antioxidants. Antioxidant vitamin examples would be vitamin A, vitamin C, vitamin E, and these are like scavengers. They sort of soak up free radicals. The free radicals interfere with the skin's ability to heal and the normal biological processes that, through which that takes place. So eating a good healthy diet with lots of fresh fruits and colored vegetables, and then zinc. You may want to supplement a healthy diet with zinc. Zinc has been shown to be important in good skin health and hair health as well. And be patient with your skin. I mentioned earlier that there are elastic fibers in the skin, and you can kind of picture it like an elastic waistband. You stretch it out, there's some ability for it to snap back to some degree. Some people are blessed with better skin than others with respect to elasticity, but I think that the recommendations for our patients is to wait at least 12 to 18 months after weight loss surgery before considering any body contouring. And I think that may not be enough. For my patients, I recommend waiting 12 to 18 months after your weight has stabilized. After you've stopped losing weight, be patient. Give your skin a chance. It's a dynamic organ. It covers our entire body. And then do all the things that promote good skin health. After a period of patience, if you have areas that are bothering you, then body contouring may be appropriate. It is encouraged in our clinical practice guidelines. And so after a period of patience, I recommend go back and see your bariatric surgeon and a plastic surgeon and let them help you address what concerns you may have regarding excess skin. As it turns out, most insurance companies actually do cover skin and body contouring. The general perception is that it doesn't, only because most plastic surgeons that do this work, they don't participate with insurance companies. So they're not bound by the rules of contracting with insurance companies. But body contouring is really no different than having weight loss surgery. Most policies, most insurance policies have a set of criteria that if the patient meets those, then it will be considered medically necessary and covered by your insurance plan. Okay, I'd like to skip now to the dumping syndrome. And who's affected by the dumping syndrome? Well, basically, I see a couple of hands go up. If a person has a very small stomach or what's called a gastroenterostomy, then you'll be predisposed to having the dumping syndrome. So a gastroenterostomy, just for those of you who may not know, that's just when you take the small intestines and you connect it directly to the stomach. Well, normally humans, when we eat, we have our whole stomach available to hold food. It's a large reservoir, and the food actually stays in the stomach for a while. And in the stomach, the food is diluted by gastric juices, and the digestive process actually starts. So there's the acid in the stomach will start to break down the food a little bit. And then at the bottom of the stomach, there's a valve, right? The pyloric valve. Pylorus means gatekeeper. It's the gatekeeper of the stomach. And what it does is it just lets a little bit of that food out at a time that's been diluted and partially digested. And that is how the small intestines likes to see food. Small amounts, pre-digested and diluted. So the issue is, if you have a very small stomach, then the smaller the reservoir, the faster it empties. And if you have a gastroenterostomy, the food literally, there's no pylorus to control it, and so the food literally dumps into the small intestines. And that's where we get the term dumping syndrome. And so if you get the rapid delivery of these concentrated foods like sweets or carbohydrates or fatty foods, and they're dumped directly into the small intestines full strength, the small intestines responds by secreting what we call vasoactive compounds, things like neurotensin, vasoactive intestinal peptide, insulin, and glucagon, and these produce effects on our body. The people who are primarily predisposed then are patients who've had a gastric bypass, a biliary pancreatic diversion without duodenal switch, or even the sleeve gastrectomy. Now, most people think that a sleeve gastrectomy patient is not going to have the dumping syndrome because they still have a pyloric valve. But remember, the sleeve is going to fall into that category of a very small gastric reservoir. And the smaller the reservoir, the faster it empties. And about 40% of sleeve gastrectomy patients have dumping symptoms in the dumping syndrome. If a patient, though, is even with a small gastric reservoir or a gastroenterostomy, eats what I call healthy foods, then the dumping syndrome is usually not provoked. So if a patient eats lean animal proteins baked or grilled, colored vegetables, green, yellow, red, orange vegetables, and fresh fruits, those don't typically cause the dumping syndrome. It's usually starches, concentrated sweets, and concentrated fats that will produce it. So it can kind of be broken down into two phases. The early phase is primarily intestinal type symptoms, although there are certainly flushing, abdominal cramps or colicky pain, diarrhea, nausea, and vomiting. It usually occurs within the first 30 to 60 minutes after a meal. Late dumping occurs about 1 to 3 hours after a meal, and in addition to the intestinal, abdominal types of complaints, there can be some neurological symptoms. Patients can have physical weakness. They can even faint due to the dumping syndrome and pass out, which can be very dangerous. There's also something that's being talked about more in the medical community with respect to dumping, and that is the hyperinsulinemic hypoglycemia that occurs with dumping. What do I mean by that? Well, if you have starches or concentrated sweets being dumped into the small intestines, what happens is about an hour or two after surgery, the blood sugar goes quite high. Well, the body's natural response to high blood sugar is to release a bunch of insulin. So you get this hyperinsulinemic response that then brings the blood sugar right back down. And it does so fairly promptly. When you get a rapid change in blood sugar like that, it's almost like a diabetic who accidentally took too much insulin. They get very shaky, weak, and they crave carbs. They've got to have them to bring the sugar back up. And so there's been some concern about this hyperinsulinemic hypoglycemia that develops if it promotes hunger and craving for carbs about 2 to 3 hours after eating a meal. It may promote snacking and weight regain. And so there's some discussion about this amongst the medical community. All right, kidney stones. Again, who's affected? Basically, we have learned over the years that patients who have a gastric bypass or a biliary pancreatic diversion, with or without the duodenal switch, have a significantly increased risk of kidney stones. Does anybody have any problems with kidney stones since their weight loss surgery? Quite a few people raising your hands. All right, so I feel like this is one of those subjects that's a little bit misunderstood. These stones are calcium oxalate stones. And after the bypass and the biliary pancreatic diversion, we absorb more oxalate in through our GI tract. And so how do we prevent these stones? The stones are made out of calcium oxalate, and yet one of the recommendations is to make sure you are supplementing with calcium. Now that's kind of counterintuitive because you have calcium stones. But what happens is if you supplement with calcium, as we should based on our clinical practice guidelines, the calcium, while it's still in your GI tract, binds to the oxalate, and then you don't absorb the oxalate. So the calcium actually helps you get rid of and prevent you from absorbing the oxalate. The next thing to know is that you need to have a low sodium diet. Less than 2 grams of sodium per day is recommended. If the more sodium you eat, the more calcium you secrete in your urine. And these stones form when either the calcium level gets too high in your urine or the oxalate gets too high in your urine, and it can't stay in suspension. It starts to form little crystals that grow into stones. High citrate. Citrate is important, and you need to supplement your diet with citrate if you're struggling with kidney stones, because the citrate will be excreted in the urine, and it binds to the calcium in your urine. In your urine, that combination is very soluble and doesn't precipitate out to form stones. So the good news is that most of the available supplements provide calcium in the form of calcium citrate. So if you're following the clinical practice guidelines, you'll probably get an adequate amount of calcium and an adequate amount of citrate. But just don't make the mistake of limiting your calcium after, if you're having kidney stones. Probiotics. Some bacteria actually eat oxalate. They consume it as an energy source. And so supplementing with probiotics can minimize kidney stones as well, because it never gets a chance to get absorbed if the bacteria consume it as a food source. Water. Obviously, this one actually makes sense. The more water you have, the more urine you'll make. Your urine will be dilute, and you'll be less likely to precipitate crystals out and form stones. So make sure you're following your medical team's recommendations about fluid intake. And you need to have a low oxalate diet. So that means avoiding things like beets, spinach, rhubarbs. Most nuts are fairly rich in oxalate. Wheat fiber can be high as well. And unfortunately, and don't kill the messenger, but chocolate and strawberries too are not on a low oxalate diet. So I find that sad. All right, nutritional deficiencies. A lot of discussion, a lot of research done about nutrition after weight loss surgery. But as it turns out, people who are seeking weight loss surgery have a very high incidence of nutritional deficiencies even before surgery. In my practice, 70% of my patients are vitamin D deficient before surgery, 50% are iron deficient, 50% are magnesium deficient. And none of these operations make that better. Excuse me. Now, with respect to protein, there almost never see significant protein deficiency develop after the adjustable gastric bandings, the sleeve gastrectomy, or even the gastric bypass. It's pretty rare to see a protein deficiency develop. Typically, we associate these with the operations that we would have termed malabsorptive. So things like the distal gastric bypass or the biliary pancreatic diversion with or without duodenal switch. It's recommended, excuse me, but postoperative deficiencies with vitamins and minerals and protein can develop in those patients. Excuse me. After the duodenal switch and the distal gastric bypass, it's generally accepted that patients can absorb about 75% of the protein that they consume and about 75% of the carbohydrates that they consume, but they only absorb about 25% of the fats. So these operations are really primarily malabsorptive when you're talking about fat in the diet. They do have an effect on protein and carbohydrates too. So if you have an average patient whose body needs 75 grams of protein a day for good health, and they have a distal gastric bypass or a biliary pancreatic diversion, then they're going to need to actually consume about 100 grams of protein a day to absorb the 75 grams that their body actually needs. Okay? When you're talking about protein, I also want you to make sure that your body is getting a good quality protein. There's something that we judge the quality of protein in our diet called the PDCAAS score. It's the protein digestibility and, corrected amino acid score. And basically it's an assessment of the protein and how suitable it is for humans. That is, the amino acids in the protein needs to fulfill all of the requirements that a human body needs, and it also takes into account how digestible the protein is. So excellent sources of protein are things like whey protein, milk, egg, and soy protein. Those all have very, very high PDCAAS scores. But there are so many protein supplements out there, I encourage you to really learn how to read the labels and be critical. I have seen things whose name would imply that they were a whey protein. But when you look at the ingredients, you find out it's actually a collagen-based protein, which has a relatively low PDCAAS score. So be aware, be actively involved in making sure that you're getting the proper type of protein that your body needs. Now, with respect to vitamins and mineral deficiencies, these are really common. I mentioned the fact that most of our patients have them to some degree before surgery. So I'd like to make a distinction between treating a deficiency and what we call prophylaxis, right? Prophylaxis with respect to supplements, what we're talking about is you have a patient who has no nutritional deficiencies, they have weight loss surgery, and prophylaxis is the supplements that they take to try to prevent them from developing a deficiency, and that is different than treating a deficiency that's pre-existing. So two different categories. So with respect to prophylaxis, most of you, I hope, are familiar with the clinical practice guidelines. Basically, before 2008, we had, as practicing physicians, no published or acceptable comprehensive guidelines that we could use to guide our patients with respect to what they should be taking after surgery. There are nutritional consequences for the operations that we do for our patients. And so in 2008, the Obesity Society, the American Association of Clinical Endocrinologists, and the American Society for Metabolic and Bariatric Surgery published their first set of clinical practice guidelines. Those guidelines were actually updated last year, and they are the most comprehensive set of guidelines that we have for appropriate supplementation after weight loss surgery. Now, they're not going to be perfect for everybody, but I think they're the best starting point we have. And so I encourage everybody to familiarize themselves with what is in these clinical practice guidelines and make sure that what you're taking is appropriate for the procedure you've had, because it does vary a little bit between procedures. Weight loss. Now, to me, this is probably the most important of the topics that we'll be talking about. When we talk about long-term bariatric patients and weight loss, what we're concerned about is either inadequate weight loss or weight regain. And, excuse me. So that begs the age-old question of who failed whom. Did the surgery fail the patient, or did the patient fail the surgery? Well, I think, 10 years ago, I think most surgeons, including myself, would have said that the patient failed the surgery because the patient wasn't compliant, right? But there's been some really exciting research in the past 5 to 10 years that when you look at it and look at the reality of what we experience in private practice every day working with our patients, today I would say that the surgery failed the patient, which is very different thinking. And what do I mean by that? I'm talking about the concept of the metabolic set point. Anybody heard of that? A few of you. I'm glad to see that. So, what we're talking about is that our bodies defend how much energy we store. And that level of energy storage, or fat storage, is vigorously defended physiologically. And that level that's defended we call our metabolic set point. And our bodies defend that and protect it through an interplay between our brains, our adipose tissue, our intestines, and organs like the pancreas. so that when we go on a diet, our brain receives signals from the adipose tissue that there's not as much of it. The brain will then turn around and shut down our metabolism so that the amount of energy we expend during a day goes down. There's also an increase in hormones being secreted that make us feel hungry. Those are called orexigenic hormones. And then there's a set of hormones that we make that make us feel full and satisfied. And the amount of those hormones when we diet are decreased. And so that the end result is we get very hungry and we eat and we gain the weight that we lost back to that metabolic set point. The body vigorously and actively defends this. And what's really amazing is that weight loss surgery actually alters our physiology. So it's not like just going on a diet. It's not an enforced diet. And that's why you'll find us talking less about restriction and malabsorption than we used to, and talk about the fact that some of these operations are metabolic because they change our physiology. They change our body's response to food and weight loss in a way that moves our metabolic set point to a healthier level of energy or fat storage. Because the only issue with our metabolic set point in our severely obese patients is that it's just not healthy for them. Excuse me. So orexigenic hormones, the most popular one and most well-studied is ghrelin. I'm sure most of you are familiar with that. Ghrelin is made in the fundus of the stomach, and when we go on a diet and try to lose weight, we secrete more ghrelin. But some of the operations we do practically, or for all intents and purposes, eliminate ghrelin production. Anorexigenic hormones or compounds, examples of that from the intestine would be glucagon-like polypeptide 1, peptide YY, and even cholecystokinin, and amylin from the pancreas as well. And so understanding this metabolic set point in physiology in light of weight regain and inadequate weight loss, it's apparent, or intuitive at least, that some of the operations that we have probably change the physiology more than others. And intuitively to me that makes sense, and it fits with what we observe in our patients on a day-to-day basis. And so when we're talking about inadequate weight loss or weight regain, the adjustable gastric bands on average have the highest incidence of inadequate weight loss or weight regain, but they don't change our physiology at all. The sleeve gastrectomy, the bypass, and the duodenal switch are considered metabolic operations. So with the sleeve gastrectomy, it's not really been around long enough for us to say what the risk of inadequate weight loss or weight regain is going to be. But the sleeve behaves very much like the gastric bypass in every metric that we can measure. Weight loss the first year or two after surgery, resolution of comorbid conditions, the risk of the surgery. So it's reasonable to think that the weight regain or inadequate weight loss with the sleeve is probably going to be similar to that we see with a gastric bypass, but we really don't know. Now, the gastric bypass has been around for about 50 years, and so we do have a good track record. We know that the incidence of inadequate weight loss or weight regain with that is going to be 20 to as high as 30% of our patients will have some weight regain. Now, some will regain a little, and some patients, unfortunately, regain a lot. The duodenal switch probably changes our physiology the most, and it has the lowest associated incidence of weight regain or inadequate weight loss, around 5% of our patients. So I think that, to me, what's liberating about this concept of the metabolic set point is that I'm hoping it will take away some of the negativity and the feelings of failure that my patients express to me, because some of it actually just happens automatically with the surgery. And if the surgery doesn't change our physiology enough, then we just need to continue working on it and do something else. Obesity is a chronic disease, and there's technically not a cure for chronic diseases, but we manage them and we treat them. And so I find this whole concept of the metabolic set point very liberating, and I hope you do too. If you have any questions, I'd be happy to do my best to try to entertain those. Yes, ma'am. The question is there a way to know how much protein is efficient for yourself? I don't think there is. You know, I think everybody's different. We all have a different physiology. And I think that these recommendations that we have are generally good. But as I mentioned earlier, I don't think they're going to be perfect for everyone. Some of my patients who have a duodenal switch may do absolutely fine with 80 to 100 grams of protein a day, and yet others may need 150 grams of protein a day in order to get enough into their body. And so I don't think there is a way to figure it out. It's kind of empirical. And so it's very important that you have lifelong surveillance with your primary care physician or your bariatric surgeon, and you get the appropriate lab test done. Because if you're eating 100 grams of protein a day and your albumin's 2.4, you need more. Yes, ma'am?
Do you know where we could get the latest clinical practice guidelines?
Sure. The update published in 2013 was published in SWORD, the Surgery for Obesity and Related Diseases, and I would be happy to email a copy of that to you if you can find me afterwards. But it's published and it's out there, and hopefully your multidisciplinary team has a copy of that and is using that as a basis for their recommendations for you. Yes, ma'am. Okay, I'm sorry, I didn't really make that very clear. Typical parameters that we check when looking at for adequacy of protein is something we call the prealbumin level, the albumin level, and the total protein in our blood. Now, it doesn't work very well, especially the prealbumin. I used to be really excited about it, and then just over time I've learned that there are so many things that influence your prealbumin level that it's really almost an acute phase reactant, and if there's anything else going on, it's hard to use it. But you kind of have to take all your best information. But yes, albumin is one of the things that we look at for adequacy of protein levels. Yes, ma'am. Yes, ma'am.
For post-bariatric patients, is gallstones something that we need to be concerned about? I had an emergency trip to the hospital, and they're going to be some tests thinking that I have a gallstone problem now, and it's difficult.
Yes, the question is about gallstones. And how in the world did a general surgeon forget to put gallstones up here? Thank you for bringing that up. You know, in what I call the old days, which I was a part of, the pre-laparoscopic revolution, we used to routinely take the gallbladder out at the same time that we did the weight loss surgery, because the weight loss surgery involved a big incision. The gallbladder surgery involved a huge incision too, and there was a significant amount of morbidity with that. Currently, although I think it's some degree controversial, most of us do not routinely remove the gallbladder at the time of weight loss surgery, because probably only 15% of the patients are going to develop symptomatic gallstones down the road. And it has also been recommended to consider using gallstone dissolution therapy prophylactically after weight loss surgery, meaning things like ursodiol or something, probably reduces the risk of developing symptomatic gallstones much, much lower, probably less than 5%. But yes, 15 to maybe 20% of our patients after significant weight loss may develop symptomatic stones that may require gallbladder removal.
So
There is some overlap, certainly, with the nausea, vomiting, and crampy, severe crampy abdominal pain. Is typically felt right in the middle or off to the right is with a gallbladder. With the dumping syndrome, you know, the dumping syndrome is highly variable. Some people say, I don't dump at all. Other people are exquisitely sensitive to it, and it can be manifest in different ways, too. Yes, ma'am. The question is about the development of irritable bowel syndrome after surgery. Is that right? Okay. So I really think of irritable bowel syndrome as a medical condition, a functional problem, and I do see it in my patients both before and after surgery. I don't know of any relationship as far as cause and effect of you didn't have it, you had weight loss surgery, and then you had it. I don't know about that. I've never read anything about that. Uh-huh. Someone had mentioned that that was the case. Oh. I'm not aware of that. But there's probably a lot of things I'm not aware of, so. Yes, ma'am. All right.
Are there any, dealing with Roux-en-Y especially, concerns that we need to watch further out as far as developing problems like ulcers or
Yeah.
what you're bleeding? I've had several people when you hit the 5-year mark that got out,
Mm-hmm.
developing problems where they need to go in and make little adjustments here.
Right, with a gastric bypass. Yes, unfortunately, there is an increase of ulcers after gastric bypass, or any time you take the small intestines and you attach it to the stomach, there's an increased risk in ulcers. That is especially aggravated if a patient takes any form of anti-inflammatory drug like aspirin or ibuprofen. Cigarette smoking is really a problem for most gastric bypass patients. I've seen a few who smoked and didn't get ulcers, but usually they actually get very refractory ulcers that will not heal no matter how much medicine we use. I've gone so far as to have to convert a gastric bypass patient into a sleeve gastrectomy due to non-healing ulcers in a patient who just, despite their best efforts, were unable to quit smoking. So ulcers is one that is, I think, a particularly increased incidence for the bypass patient. Very common.
I get a lot of questions from my patients about long-term bone health, and I'm just curious what recommendations you make to our stapled patients in particular in terms of surveillance long-term for bone health.
That's an excellent question that I was hoping no one would ask. Thanks a lot. I think bone health is one of those very important potential problem areas that is not usually talked about. I find it particularly complicated because there's a lot of bone health issues in patients who don't have weight loss surgery, particularly women with osteoporosis, osteopenia. Most women that I'm aware of are not taking adequate calcium supplementation of 800 to 1,200 milligrams a day, and these are people, I'm not talking about weight loss surgical patients. And so there's a high incidence, as you know, of secondary hyperparathyroidism due to vitamin D deficiency, which is almost epidemic in our population, and the weight loss surgical population is no different. And so it gets very complicated, and basically my thinking is that I don't fully understand it, and I want to just make sure that I'm following the guidelines. I want to be following my patients on a regular basis and making sure that any nutritional issues that may aggravate osteoporosis, osteopenia down the road are being looked at. And then I am not familiar with the recommended screening intervals for DEXA scans and things like that. In my community, it's the primary care doctors who are doing most of that. But I go back to the beginning, and I just want to make sure that we're addressing vitamin D, because that very much affects our bone health, our adequacy of calcium supplementation, and and all the nutritional parameters. Yes, ma'am.
I was wondering what the long-term effects of malabsorption and weight gain would be if your anastomosis stretches out, and at what point would you realize that it has stretched out too much?
And are you talking about with a gastric bypass? Okay. So the question was about malabsorption long-term and the anastomotic dilation. All right. I think that most of the gastric bypass connections, the anastomosis these days between the small intestines and the pouch, are done stapled with perhaps an element of hand sewing. And those are going to naturally dilate over time. There's a great deal of controversy within the surgical community about whether or not that is important for long-term maintenance of weight. One camp believes size matters and the other camp thinks it doesn't. And they're good arguments. You have surgeons who make very large anastomoses, and their patients' weight loss is no different than a small anastomosis. I'm not sure that it really makes that much of a difference for the maintenance of the long-term weight loss, because I don't think of the pouch as holding the food. The pouch, in the way I think about the gastric bypass, is really a pass-through. The only reason we keep a little pouch there, in my opinion, is because you can make a very safe connection between the small intestines and the stomach, because the stomach tissue is thick and it holds stitches and staples very well. The esophagus doesn't. We've known for decades that if you take the small bowel and get rid of all the stomach and hook it up right up to the esophagus, you're going to have a much higher incidence of complications, leaks, strictures, and problems. So the pouch, in my mind, is a pass-through. The pouch doesn't hold the food. And if that's the case, then the size of the actual anastomosis is probably of minimal importance for long-term maintenance of weight loss. With respect to malabsorption in the gastric bypass, there's general acceptance that after these operations, where the bowel is partially bypassed, that there is some significant bowel adaptation that occurs over the first 3 years or so. And so I don't consider the gastric bypass to be a malabsorptive operation in terms of the way I talked about the DS and the distal gastric bypass, where they only absorb 25% of their fats. Because in fact, food is still going through 85 to 90% of our gastric bypass patients' small bowel. But there are consequences of bypassing that proximal bowel where a lot of calcium gets absorbed and things like that. So I don't consider it a highly malabsorptive operation, especially if you're 3 or more years out from surgery. Yes, ma'am.
Can you talk about the relationship between bariatric surgery and diabetes, and what is the feeling in terms of whether or not the diabetes might come back or a better outcome with the diabetes or no diabetes at all?
So diabetes and weight loss surgery, obviously, is one of the most exciting parts of doing weight loss surgery for me, is seeing resolution of diabetes. But there is an incidence of diabetes recurring years down the road. It's been particularly reported after the gastric bypass. I don't think anybody really understands how much the patient's diet is playing a role there, perhaps, as far as carbs. And I kind of fall back to the extent or the density of the physiological change that the operation imparts to allow continued resolution of the diabetes. And what I'm thinking when I say that is we see that recurrence of diabetes a lot more with a gastric bypass than we do with a duodenal switch, where 15, 20 years down the road, diabetic resolution rates in excess of 90% are typical. We don't know about the sleeve yet, but I think as we learn more, it appears to me that it has to do with how much the operation changed the physiology.
So that's with or without
With or without?
regain?
Oh, weight regain? I think that the recurrence of diabetes is associated with weight regain. Cause and effect? I don't know. Yes, ma'am.
What would you recommend? I have a friend that is 12 years out of RMY. He's had a double hip replacement, and he is
something to try to help him fix his bones. Gosh, I don't know. If he were my patient, I'd probably refer him to a mineral metabolism center. They're usually associated with very large universities, and just see if they can detect any sort of abnormality that he has that might be beneficial, but that's a complicated problem. Yeah. You're welcome. Yes, ma'am. I got the wrap it up sign, so this will be the last question. Go ahead. No, she was telling me to wrap it up. So you're on.
Okay, I'm on. I just recently read, I guess I had never listened before and heard, why can't take time-release medications?
I don't know that that's really true. I'm going to just talk about my practice. The only people that I recommend not taking time-release medications are the distal gastric bypasses and the biliary pancreatic diversions with duodenal switch. There's a concern because they're only using half their bowel that it won't get absorbed. But with a typical gastric bypass patient, the medicine is still going to go through about 85 to 90% of the bowel. There's probably going to be time.
Thank you.
You're welcome. Thank you all.